In addition to providing immediate feedback about left and right ventricular function, echocardiography is also the gold standard for the diagnosis of the mechanical complications of infarction. Detection of these complications is usually vital for appropriate management decisions. The complications which we will now illustrate include pericarditis with pericardial effusion, true aneurysm, acute ischemic cardiomyopathy, mural thrombus, and cardiac rupture. This latter complication can be subdivided into rupture of the free wall, rupture of the ventricular septum, and papillary muscle rupture. Pericarditis can occur during the first several days following transmural myocardial infarction via extension of the infarct to the epicardium, or it can occur weeks to months after the acute infarct with an autoimmune mechanism, the so-called Dressler's syndrome. In either instance, there is often associated pericardial effusion. This patient has an apical infarct, which will be better appreciated in real time. A small pericardial effusion is evident lateral to the left ventricle and around the right atrium. In general, pericardial effusion associated with myocardial infarction is small to moderate in size. Fortunately, tamponade is rare following myocardial infarction. When it does occur, it should raise the possibility of cardiac rupture. This is a specimen from a patient who expired following an anteroseptal apical infarct. This is an apical aneurysm, which is well demarcated from the normal lateral myocardium at mid and basal levels and the basal anterior wall. A huge thrombus fills the aneurysm. This region, leading from the mid-ventricle into the aneurysm, is referred to as the neck of the aneurysm. True aneurysms have wide necks. In this case, the width is equal to the short axis LV diameter. This is the 2D exam from a patient who suffered an anteroseptal apical infarction complicated by an apical aneurysm. There has been tremendous expansion of the apical one-third of the ventricle. This is thrombus, which is frequently present in aneurysms. As was the case with the preceding path specimen, this true aneurysm has a wide neck. In real time, you will see normal contractility of the right ventricle. The infroseptal segments and the lateral segments at base and mid-level also contract normally, while there is a discrete apical aneurysm with dyskinetic motion. The four-chamber view has now been modified slightly to more clearly define the apical thrombus. In the two-chamber view, dyskinesis of the aneurysm is again apparent, while the anterior and inferior segments at base and mid-levels contract normally. When considering aneurysmectomy, it is important to delineate the function of the non-aneurysmal portions of the left ventricle. The more vigorous the contractility of the basal and mid-ventricular segments, the more likely that aneurysmectomy will be highly successful. This patient survived a massive anteroseptal apical infarction and has developed a huge apical aneurysm. His ejection fraction was calculated as less than 10%. Note this spontaneous, swirling pattern within the left ventricle, which can be seen in severe low-output states. Because of the normally contracting basal and mid-level inferior and lateral walls, he underwent successful aneurysmectomy. This specimen has been sectioned in short axis at the basal level of the left ventricle. This patient expired following a lateral myocardial infarction. The infarct has expanded to form a lateral basal aneurysm. Lateral basal and infrabasal aneurysms are far less common than apical aneurysms. Note the wide neck of the aneurysm. This patient suffered an inferior infarct, and this is the resultant infrabasal aneurysm filled with thrombus. This patient had prior apical and inferior infarcts. The inferior infarct has resulted in formation of an infrabasal aneurysm. The neck of this aneurysm is also wide, extending from the mitral annulus, here at the base of the posterior mitral leaflet, to the base of the posteromedial papillary muscle. You can see that the papillary muscle has also been infarcted. It is thinned, echodense, and stretched across the neck of the aneurysm. Such patients usually have associated significant mitral regurgitation. Furthermore, if a decision is made to resect these aneurysms, the surgical procedure will usually have to involve mitral valve replacement as well. Note the severe reduction in LV systolic function. Maintaining the apical long axis format, the transducer has been tilted slightly to delineate the mural thrombus within the aneurysm. In real time, the transducer will be tilted even further to reveal the full extent of the thrombus. Once an infrabasal aneurysm is identified, this type of medial and lateral scanning is always indicated. This patient's first symptom of coronary artery disease was acute infarction, and he presented to us several hours into the infarct in a severe low output state. Echocardiography demonstrated that this was due to massive left ventricular involvement, resulting in an acute ischemic cardiomyopathy. This is a subcostal four-chamber view. His infralateral wall shows some preservation of contractility, but this is offset by septal dyskinesis. The apical two-chamber view also reveals very minimal contractility. He unfortunately presented prior to the advent of acute interventional therapy and died despite vigorous support within several hours of admission. The severe acute reduction in left ventricular function is underscored by this subcostal short axis scan from apex to base. The only wall with normal contractility is the lateral. We have already illustrated chronic mural thrombi that had formed in apical and infrabasal aneurysms. This is a specimen from a patient with an anteroseptal apical infarct. Note the thinning of the septum and of the anteroapical segment. A large thrombus protrudes from the apex into the left ventricular cavity. This is another patient who died following anteroseptal apical infarction. There is thinning of the septum, including the very basal portion, and the thinning extends to the apex, including the infraoapical segment. This is a large laminated thrombus at the apex. Here is a third specimen with anterior infarction. In this case, the short axis section shows thinning of the anterior septum and anterior free wall with infarct expansion. Note that the inferior septum is normal. This is a large mural thrombus. This 2D study is from a patient with an acute anteroseptal apical infarction. The apex is packed with thrombus. In apical long axis format, the extent of the infarct and the apical dyskinesis are more apparent. In apical two-chamber format, you can see the marked dyskinesis of the anterior wall. With all this rocking, you can see why there would be a tendency for this thrombus to embolize. This patient was studied prior to hospital dismissal. Despite acute thrombolytic therapy, he sustained a huge anteroseptal apical infarction. In this four-chamber view, there is density at the apex that is suspicious for thrombus. These two small, rounded thrombi are more apparent on this apical short axis view. Patients with acute infarction and thrombus clearly identified by echo are at significantly increased risk of embolization. We anticoagulate with heparin as soon as a thrombus is identified and place the patient on Coumadin for 4 to 6 months. This 72-year-old female presented with an acute anteroseptal apical infarct. Once more, thrombus is evident at the apex. We are now imaging in apex down format and have scanned the apex to more carefully delineate the thrombus. In real time, you will see that there are 3 mobile parts of this thrombus. 1 here, attached to the anterior wall, and 2 here at the apex. This is an expanded view of the apex. These mobile thrombi have the greatest tendency to embolize. They require very aggressive anticoagulation. This 70-year-old female was admitted to her local hospital with an acute inferior myocardial infarction. She remained stable and was transferred to us several days later for routine post-infarct investigations and rehabilitation. This echo was obtained to assess her degree of left ventricular dysfunction. She has a small pericardial effusion. It is immediately apparent that her right ventricle is enlarged. For the moment, we will focus attention on her left ventricle, which is normal sized. In real time, you will see that her global LV function is normal, but her inferior wall and inferior septum are akinetic. Her right ventricle is enlarged. The transducer has been tilted slightly to focus on the inferior wall of the right ventricle. In real time, you will see that it is akinetic. Her RV infarct was clinically unsuspected. Apical imaging was technically difficult, but it is still apparent that her right atrium and right ventricle are enlarged. This mass of echoes attached to the free wall of the RV is a mural thrombus. The image has been expanded to concentrate attention on the thrombus. Right ventricular mural thrombus is a well-recognized complication of RV infarction. Dislodgement would, of course, result in pulmonary embolism. Therefore, despite the small effusion, this patient was placed on anticoagulants. She went through her rehabilitation program without incident. This is a pathologic specimen from a patient who suffered a relatively small apical infarction and expired when the apex ruptured. This is the small rupture here. The heart has now been sectioned to demonstrate the apical infarct. The pointer extends through the rupture. This is an extremely frustrating problem, which accounts for 10% of all in-hospital deaths following acute myocardial infarction. The patients usually experience pain, become suddenly bradycardic, and then arrest due to sudden cardiac tamponade. Here is an anterior free wall rupture, which resulted in death due to sudden hemopericardium. These pathologic specimens are oriented such that we are looking from the base towards the apex. This is the anterior wall, which is hypertrophied. The inferior wall is infarcted. This patient was recovering nicely until his inferior wall ruptured and he expired. Sometimes free wall rupture does not cause tamponade because of pericardial adhesions in the vicinity of the rupture. In such cases, the rupture is contained by the pericardium and leads to formation of a pseudoaneurysm. This specimen is from a patient with an infralateral infarct which ruptured, with formation of a pseudoaneurysm filled with thrombus. The rupture itself forms the neck of the false aneurysm, which is quite narrow, in contrast to the previously displayed true aneurysms. This 2D study is from a patient with a pseudoaneurysm. This is a peristernal long axis view. Left atrium, mitral valve, aortic valve, left ventricle. There is a cystic space adjacent to the left ventricle. This is the pseudoaneurysm. This patient had an infralateral infarct which ruptured. Here is the narrow neck of the pseudoaneurysm. Pseudoaneurysms are lined only by pericardium. Therefore, there is a significant risk of rupture. Surgery should be planned as soon as a pseudoaneurysm is identified. Doppler can be used to verify communication with the ventricle. In systole, there is flow from the left ventricle into the pseudoaneurysm. In diastole, there is flow from the pseudoaneurysm to the left ventricle. This patient was transferred to us 1 month after an acute infarct because of continued chest pain with dyspnea. An apical aneurysm has formed. On this apical two-chamber view, there is a large mass of echoes adjacent to the inferior wall and apex. The texture is consistent with thrombus. On subcostal examination, the RV is compressed. This has the appearance of pericardial fluid, and it merges with the large thrombus accumulation which overlies the apex. You can identify the apical myocardium here. It has a slightly greater density than the thrombus. This is parietal pericardium. Therefore, this is pericardial hematoma, which is the result of rupture of the LV apical aneurysm. True aneurysms rarely, if ever, rupture in their chronic fibrotic state. However, they can rupture, like any other infarction, during the first several weeks when the infarcted tissue is still soft. This patient underwent successful surgical excision of the pericardial hematoma and of the true aneurysm. We are often called to cardiac arrests involving acute infarct patients who develop electromechanical dissociation. The hope is that we will identify a rupture with tamponade which can be relieved by centesis while the surgeon is being called. In many of these instances, however, we have found the patient to have true electrical mechanical dissociation. This is a subcostal view with the patient being ventilated. Compressions are being held. The rhythm is paced. A temporary pacemaker was inserted earlier in the resuscitation effort. At this time, there is still a slight amount of contractility of the anterior and lateral walls. This image is in 4-chamber format. This is the temporary pacemaker in the right ventricle. This motion of the image is due to chest compressions, which had been resumed. Note that subcostal imaging does not interfere with the resuscitative effort. Now the compressions have been held again. The pacemaker is only capturing intermittently, but even with capture, there is no myocardial contractility. This is true electromechanical dissociation. Rupture of the ventricular septum during acute myocardial infarction with resultant left to right shunt usually produces a low output state and leads to poor prognosis. This complication is best managed by prompt diagnosis and surgical repair. This frame is an inferior scan in apical 4-chamber orientation. Here is the os of the coronary sinus. This patient had an inferior infarct and then developed a new holosystolic murmur. This is the rupture through the inferior ventricular septum. Still using the apical transducer location, color Doppler demonstrates flow from left ventricle across the defect and out toward the RV apex. This is a parasternal short axis view at the basal level. The defect is again seen to involve the inferior ventricular septum. In real time, you will see that this is dyskinetic, while the adjacent inferior wall is akinetic. Color flow imaging again demonstrates the shunt. Color seems to seep through the septum from left ventricle to right. This is an apex down 4-chamber view from another patient with inferior infarction that involves the inferior septum. With inferior scanning, ventricular septal rupture has been identified. The rupture involves the basal portion of the inferior septum, and the defect then tracks along the RV side of the septum to enter the RV at mid-ventricular level. This flap is RV endocardium. This type of VSD, which dissects its way distally through the septum, is classified as a complex VSD. In a Mayo Clinic pathology series, Doctors Brooks Edwards and Bill Edwards found that complex septal ruptures are most common with inferior and basal infarctions. This patient had an aneroseptal apical infarct. This septal defect is classified as simple since it is straight through the septum from left ventricle to right ventricle. This patient presented with an aneroseptal apical infarct and then deteriorated coincident with the appearance of a new holosystolic murmur. Surface echo was technically difficult, but on this apical long axis view, you will be able to appreciate the akinetic anterior septum. On the apical 4-chamber view, there was suspicion of a septal rupture near the apex. The situation was fully clarified via transesophageal echocardiography. The transducer is in the esophagus, behind the left atrium. This is the left ventricle, and this is the apical septal rupture. This is a 2D example of a simple VSD, straight through the septum from left ventricle to right. Color flow imaging confirms the shunt from left ventricle to right. During acute myocardial infarction, there is frequently associated infarction of the mitral papillary muscles. The tricuspid papillary muscles are much less commonly involved. This is a schematic of an infarcted posteromedial papillary muscle. Infarction of the muscle usually results in dysfunction leading to mitral regurgitation, the severity of which may vary from mild to severe. Papillary muscle infarction can be associated with rupture of one of the heads of the muscle, which will result in a flail segment of one of the leaflets, in this case the anterior. The sudden mitral regurgitation that results will often be severe enough to warrant urgent or semi-urgent valve replacement. Papillary muscle infarction can also be associated with partial or incomplete rupture of the trunk of the muscle. This will result in moderate or severe regurgitation. In our experience, these partial ruptures usually progress to complete rupture of the trunk. So it is prudent to refer the patient for operation at the time of identification of the partial rupture, even if the hemodynamics are relatively stable. This is a peristernal short-axis view of the left ventricle at a level near the base of the anterolateral and posteromedial papillary muscles. The patient has suffered an acute inferolateral infarct. This is pleural effusion. In real time, you will see that the septum and anterior wall are hyperdynamic. The inferior and lateral walls have not thinned, but they are akinetic. We will now scan upward to the heads of the papillary muscles. Notice the wobbling of the posteromedial papillary muscle. This is a peristernal long-axis view. This is the base of the papillary muscle, and this is the partial rupture. In systole, you can see that the distal portion of the anterior mitral leaflet is not properly supported. This is the infarcted inferolateral wall, and you can again appreciate the wobbling of the head of the incompletely ruptured papillary muscle. This is a view of the partially ruptured posteromedial papillary muscle from the apex. The descending aorta and left pleural effusion are also evident. The patient underwent successful mitral valve replacement. Complete rupture of the trunk of a papillary muscle is often fatal due to acute, wide-open mitral regurgitation. Ruptures much more commonly involve the posteromedial muscle than the anterolateral. This is a pathologic specimen from a patient who expired with complete rupture of the posteromedial papillary muscle. The tip of the muscle has completely separated from the base. This is a close-up of the head of the muscle and its chordal connections to the anterior mitral leaflet and to the flail posterior leaflet. This patient had an acute inferior infarction. He was initially stable, but became suddenly hypotensive with florid pulmonary edema. A new holosystolic murmur was noted. In this apical four-chamber view, you will notice that the global LV function is hyperdynamic. Perhaps you noticed the head of the ruptured posteromedial papillary muscle. It is in better focus on this apical long axis view. This is the base of the muscle. The head of the muscle has completely separated from the base. In real time, the head will flail back and forth during the cardiac cycle. The ruptured papillary muscle is also nicely seen in this apical two-chamber view. In real time, the inferior infarct is also evident. Following the echo, an intra-aortic balloon pump was inserted, and this patient underwent successful mitral valve replacement. This patient was hospitalized with an acute inferolateral infarct. He was transferred to us several days later when a new murmur was identified, as he became progressively more dyspneic. On his admission echo, it was quite evident that the posterior mitral leaflet was flail. The color exam was technically very difficult, although occasional systolic frames showed significant mitral regurgitation. On the apical two-chamber view, the inferior infarct will be apparent in real time. There was an impression that the head of the papillary muscle had completely ruptured from the base, but resolution was poor. The patient was intubated and an intra-aortic balloon pump was inserted. Transesophageal echocardiography was then performed. The transducer is in the esophagus, behind the left atrium. This is the left ventricle, and right atrium. The ruptured papillary muscle head is clearly seen, attached to the flail posterior mitral leaflet in the left atrium. This is an expanded view. The color flow examination leaves no doubt that the mitral regurgitation is severe. The patient underwent emergent mitral valve replacement and coronary bypass grafting and recovered without incident. As the patient with severe chest pain presents to the emergency room or is admitted to the CCU, echocardiography not only allows us to diagnose myocardial infarction and its complications, but also allows us to sort out other conditions that can masquerade as myocardial infarction. This patient presented with myocardial infarction. There is mild apical septal dyskinesis. This is the apical two-chamber view, with a segment of the descending thoracic aorta in long axis. There is severe hypokinesis of the anterior wall, with dyskinesis of the inferoapical segment, and severe inferobasal hypokinesis. On peristernal long axis imaging, the aortic root is enlarged. This is an intimal flap just above the aortic valve. The flap moves back and forth during the cardiac cycle. The flap is also evident on this suprasternal notch view at the junction of the ascending aorta with the horizontal portion of the arch. Remember that dissection can not only cause severe chest pain, but can also cause myocardial infarction via coronary dissection. Excluding this etiology of infarction is critical, prior to administering acute thrombolytic therapy. Echocardiography is also useful in identifying patients with acute massive pulmonary embolism, which sometimes is initially mistaken for myocardial infarction. Both aortic dissection and pulmonary embolism will be covered in greater detail on subsequent tapes in this series. Of course, most myocardial infarctions result from coronary artery thrombosis secondary to coronary atherosclerosis. Echocardiography can be used to visualize at least the proximal portions of the coronaries, and the resolution is improving with advances in technology. This is a parasternal short-axis view of the aortic valve from an 82-year-old male. The coronary sinuses are slightly enlarged. The transducer has been tilted to image the left main coronary. Now the transducer has been tilted to image the ostium and very proximal portion of the right coronary artery. Dr. Douglas and her colleagues at the Hospital of the University of Pennsylvania recently conducted a feasibility study for coronary artery imaging in 35 patients. They utilized an instrument equipped with an annular array transducer and a cine loop. This table summarizes the percentage of patients in whom the various coronary artery branches could be imaged and the mean length of the visualized segments. Transesophageal echocardiography will further enhance our ability to visualize the left main, left anterior descending, and circumflex coronary arteries. This is a still frame demonstrating visualization of the left main coronary artery using a transesophageal probe. The ostium of the right coronary is also visible. Color flow imaging should help in identifying areas of stenosis. In this case, the flow pattern appeared normal. The clinical utility of both transesophageal and surface echocardiography in the identification of coronary artery disease remains to be determined. Exercise echo, like exercise radionuclide testing, is used to enhance the diagnostic accuracy of the standard exercise ECG. Using supine or upright bicycle exercise, echocardiography can be performed at intervals during exercise. We prefer to use standard treadmill exercise testing, with echocardiography performed immediately after exercise. Transesophageal paced echo and intravenous dipyridamole echo are options that are being explored for situations when the patient can't exercise sufficiently, such as the patient with severe claudication. We will now describe the technique of exercise echo and then display two cases. In preparation for exercise echocardiography, a baseline resting study is performed. If diagnostic images of the left ventricle can be obtained, then post-exercise imaging will also be feasible. The point on the chest which yields the best images is marked. The patient then performs a standard graded treadmill exercise test with continuous ECG monitoring. Once the patient has reached the appropriate endpoint, they immediately lie down in the left lateral decubitus position. Images of all ventricular segments are then obtained within 2 minutes of the completion of exercise. This 64-year-old male was experiencing intermittent chest pain and was referred for exercise echocardiography. Here, his parasternal long axis and short axis resting images are displayed on the left, and the corresponding post-exercise images are displayed on the right. The frame grabber allows the examiner to capture and compare optimum cardiac cycles. This is particularly valuable for the post-exercise study, where pronounced respiration may completely obscure images from all but a few cycles. Note that all left ventricular segments displayed thicken normally. Contractility is more vigorous on the exercise study than on the resting study, which is the normal exercise response. Here, the apical 4-chamber and 2-chamber rest images are displayed on the left, with the corresponding post-exercise images on the right. The septum, lateral wall, anterior wall, and inferior wall all maintain vigorous contractility with exercise. Based on this normal exercise echo, the patient was reassured that his symptoms are non-cardiac in origin. This 51-year-old male was referred primarily for evaluation of hypertension. His ECG was interpreted as showing a possible inferior infarct. His standard treadmill exercise test was interpreted as being abnormal, but not diagnostic of ischemia. His rest and exercise apical 4-chamber and 2-chamber images have been captured with the frame grabber. His septum and lateral wall maintain normal contractility post-exercise. His anterior wall and infraoapical segment are also contracting normally. Therefore, there is no evidence of ischemia in the distribution of the circumflex or left anterior descending coronaries. At rest, note the severe hypokinesis of the infrobasal segment with moderate hypokinesis of the inferior wall at mid-level. Post-exercise, these segments become dyskinetic. This is compatible with a prior inferior infarct, with exercise-induced ischemia of the remaining viable muscle in the infarct zone. Exercise echo has been shown to be useful for risk stratification for patients recovering from acute myocardial infarction. For example, Dr. Armstrong and his colleagues prospectively studied 40 patients with exercise echo at intervals from 10 to 21 days following acute myocardial infarctions. The patients were then followed for 6 to 12 months or until the occurrence of an unfavorable clinical event, death, reinfarction, unstable angina, or coronary artery bypass grafting. For the 20 patients with no significant clinical events during the follow-up period, 13 had a negative exercise ECG, but 19 of 20 had negative exercise echocardiography. For the 20 patients who experienced unfavorable clinical events during follow-up, 11 had a positive exercise ECG, but 16 of the 20 had a positive exercise echo. Therefore, exercise echocardiography had significantly higher specificity and sensitivity than the exercise ECG for predicting adverse clinical events for patients recovering from acute myocardial infarction. In this tape, we have dealt in detail with the utility of echocardiography in coronary heart disease, including assessment of LV function, assessment of myocardial infarction and its complications, coronary artery visualization, and exercise echo. Echocardiography is a powerful, non-invasive tool in the coronary care unit. In our practice, it has become a natural extension of the physical exam, giving immediate feedback about the status of the left ventricle and allowing precise definition of all associated complications.